the transverse view with uroepithelial thickening. I can't talk about genitourinary emergencies without discussing the acute scrotum, which I think at night is probably one of the most common things that our residents have to do in the geo-emergency field. There are a number of reasons for acute scrotum. The most common one is extratesticular appendicular torsion, and followed by inflammation, and followed by torsion of the testes itself. And there are other less common reasons that you always have to keep in mind, or the clinicians should keep in mind: incarcerated hernia, insect bite, HSP, idiopathic scrotal edema, and of course, trauma. Let's talk first about testicular torsion, because that is the most important of these entities, and the one that we really, really don't want to miss. It's potentially serious with loss of the testicle, and there are two age peaks. There's a small one in the neonatal period, and then there's another peak at 12 to 18 years, but it can occur at any age. Clinical findings include nausea or vomiting, ipsilateral lower abdominal pain, swelling, hard testicle on palpation, a high-riding testicle, and an absent chromosteric reflex. Well, should we image it? Yes, we should. And how should we image it? Ultrasound is the only really reasonable tool to use. And when should we image them? Should we only image them in equivocal cases, or should we only image them when the urologist asks for it? At our institution, we image almost all of them. We came to the conclusion that it's much more accurate than the physical examination. Now, diagnosing testicular torsion is more than just there is flow or there isn't flow. There's a number of things that we can look at. We can look at the location and position of the testicle, its size, its echogenicity, vascularity, of course, and the appearance of the surrounding structures. Location and position are more clinical signs and less reliable for ultrasound. Size and echogenicity. Less than 6 hours since the beginning of torsion, the testicle will be slightly enlarged, normal, or have decreased echogenicity. After 24 hours, which is defined missed or late torsion, the echogenicity will be heterogeneous. So this is a 12-year-old boy who came in with acute testicular pain, and without even putting on the color Doppler, you can see that the right testicle is larger than the left testicle, and it's slightly more hypoechoic. But the flow on this case was normal, and he was discharged from the hospital. And he came in 3 days later with this picture. So here's his left normal testicle, and here's his right testicle. And again, I'm saying both the arterial and the venous flow was normal. This is another case. This is the left testicle. It's large, and this is the right testicle, and it's of normal size. So we don't always want to look only at the color. The vascularity can be absent, decreased, or normal. Now, the most important thing I can say, other than don't miss torsion, because it's not very nice to miss it, is always start with the asymptomatic side. Why do we start with the asymptomatic side? Because you adjust your Doppler settings on the asymptomatic side. You can miss flow, or you can create flow if you don't adjust those settings, so it is recommended to begin on the asymptomatic side first. Typical torsion is no flow, but remember, if it's less than 180 degrees torsed, it may have decreased flow. Typical example, on one side there's flow, on the other there isn't, and the settings were exactly the same. And like I said, there are other findings we can look at. There can be an enlarged epididymis and a twisted cord sign. So this is a patient that had a testicle torsion, and the epididymis is included in the torsion, so it seems very large, and as you can see, it has almost no blood flow in it. And here is an example of a twisted cord sign. Think of the epididymis as a rope, and if we twist it, then it curls up about itself, and we get what's called the twisted cord sign. And sometimes you may even see the vascularity up to the point of the twist, as you can see in this example here. Inflammation. If you're working at night, once you've ruled out torsion, the rest is sort of academic. It can always wait till the morning, but I will mention two other entities. Epididymy orchitis, it can be either just epididymis, it can be either just the testicle, or it can be both. So everything's enlarged, hypervascular, accompanying hydrocele, surrounding hyperemia and edema, and they can be together or separate. So here we have a 14-year-old boy, pain in the right testicle. It's grossly enlarged compared to the left. The echogenicity is changed, and I don't even think here anybody would have to compare to the other side to say that this is orchitis. Extratesticular appendicular torsion. The clinical finding for this is the blue dot sign, but you can't trust the blue dot sign, and ultrasound is much more sensitive. And what we find basically in appendicular torsion is a salt and pepper lesion, which is this. It can be either the appendix epididymis, or it can be either the testicular appendix or the epididymal appendix, and it will be surrounded by increased vascularity in the epididymis and the testicle and the surrounding tissue. So again, make sure you get your Doppler settings right so you don't miss this finding, and it is not an abscess. Finally, I'm going to talk about female acute pelvic and abdominal pain. Acute abdominal pain in older girls and adolescents is a common problem and a frequent cause for hospital admission. Gynecological causes must be taken into account in considering the differential diagnosis, not only in the pelvis. And there are many reasons. It can be just rupture of a functional ovarian cyst. It can be a hemorrhagic ovarian cyst, torsion, congenital uterovaginal or Mullerian anomalies. It can be pregnancy or complication of pregnancy, PID, tumors, and endometriosis, just to mention a few. And of course, it can also be stones or appendicitis. So what is a functional ovarian cyst? It's a cyst, a follicular or luteal cyst that didn't involute. And if it ruptures or bleeds, it may cause pain, and it can mimic appendicitis. And what we're supposed to see in ultrasound is just a thin-walled, simple cyst, and we do our follow-up study, and it should resolve or become considerably smaller just within a few months. Now, this is a 17-year-old girl. She came in with right lower quadrant pain, and they knew, the mother said that they know that she only has a single left kidney. Appendicitis was ruled out. This is longitudinal scan of the left side of her abdomen, and this is longitudinal scan of the right side of her pelvis. So this is a normal uterus, and this pear-shaped or Teletubby structure. Anybody know what it is? Well, she has two, one on the left and one on the right. Okay, this is her uterus, so this is, okay, hematometrium. This is a uterus filled with blood and secretions. She has a uterus D. delphis. She has failure of the two Mullerian structures to fuse. Okay, so we told the ER doctors that that was the diagnosis, that they have to send her to gynecology. I hope there's no gynecologists here. And you know, they have to do these 3D studies. I don't know what this gives them, but that's what they did. And she went on and had an MRI. So we see on MRI, okay, I have T2 with fat suppression. This is the right side showing you the exact same finding. This is the left side with the normal horn, and this is coronal scans showing the right and the left. So they gave her conservative treatment, which is hormonal treatment to stop the bleeding, so she would stop her abdominal pain, but it didn't work. In the end, she underwent surgery. She had uterus didelphys with a non-communicating right horn. Now, obstructed Mullerian anomalies are almost always associated with an ipsilateral renal agenesis. So renal agenesis in girls, if it's associated with something, it's associated with uterus didelphys. So she had a sort of expensive workup for quite a simple diagnosis. Hemorrhagic ovarian cysts, they are great imitators, and many experienced radiologists have probably misdiagnosed these as tumors, perhaps once in their career. They can have a fishnet weave or a fine reticular pattern. You can see retracting blood clots, fluid levels. They can be echogenic with posterior enhancement. And even the differential diagnosis sometimes includes an ectopic pregnancy due to the appearance. So here we have a fishnet appearance. This is a huge cyst with these reticulations in it, and this should not be confused for tumor. This is another patient who had a huge hemorrhagic cyst filling up her whole abdomen and causing pain. And you can see in the ultrasound that there is some debris in the dependent area. And finally, ovarian torsion. This is an uncommon cause of pain, but it's important to diagnose. There's usually a predisposing cause: cysts, masses, long meso, a long fallopian tube. And the clinical presentation varies from intermittent pain to really an acute crisis. The ultrasound diagnosis shows a large ovary with peripheral cysts. There may be free fluid in the pelvis, and the most important thing is presence of flow does not rule out torsion, so don't be fooled. So this is a teenager who came in with abdominal pain. This is the normal left ovary with multiple follicles, and this is very, very large, something like 70 cc's right ovary, and in the high-resolution transducer you can see the classical peripheral cysts. This is a patient from long ago that came in with non-specific abdominal pain. It's a long time ago because the CT was done before the ultrasound. And this was diagnosed as a mass. And then she had an ultrasound done, and nobody really knew what this was, and the patient underwent biopsy. And this was an old torsed ovary. So these things shouldn't happen, but it's always good to show that the presenters are also human and that mistakes are sometimes, unfortunately, inevitable. This was an 11-year-old girl who presented to the emergency department, to the adult surgeons, not the pediatric surgeons, with lower abdominal pain. And she had a CT scan. So we see on the transverse scan, on the transverse slice, this is her bladder, this is her uterus, and then there is this mass-like lesion in the Douglas area. And in the coronal scan, we see this tubular structure, which was the appendix. And this patient went to surgery with the diagnosis of acute appendicitis and a gynecological or ovarian tumor. But if you just change the window setting a little bit, you can see that this mass lesion has peripheral cysts. And what she had a torsed ovary with a reactive dilated appendix. So finally, it's really, like if you go to the RSNA, everybody says take-home messages. So first of all, I don't want you to take these home, I want you to take these to work. You should separate. And also, I looked it up, and it doesn't sound very good in French. I'm not going to even try to say it. Take-home messages. So these are take-to-work messages. So first of all, there are other important GU emergencies other than trauma. You can solve most of them with good medical history and ultrasound. Inflammation is the most common cause of hematuria, but stones are increasing in children. That's a mistake. Rule out testicular torsion. It's not just about vascularity, yes or no. Acute abdominal pain in girls, remember the ovary. And ovarian torsion, size, size, size. Thank you very much.